Hello, everyone. My name is Luyanda Majuja. I am very pleased to welcome you all to today's webinar, which will focus on pathways to patient-centered care. We are thrilled by this opportunity to gather you all as patient advocates, researchers, and healthcare professionals for this very important conversation. Our discussion today is going to explore how healthcare settings can be better reconfigured to account for the needs and values as well as experiences of the people that it serves, people living with CKD in particular. This is especially important when it comes to chronic kidney disease screening, where early detection and personalized care can make all the difference really in patient outcomes. We are also going to talk about how patient-centered care approaches can be applied to how we make CKD screening more accessible and responsive to our patient community's needs. The webinar series is produced by the Global Patient Alliance for Kidney Health. For those of you who don't know, we're also called GLOPAC. GLOPAC is a global collective of over 30 patient advocacy organizations, which are committed to ensuring that people living with CKD and their broader communities have timely access to information and screening services to ensure that they don't succumb to CKD. We believe that it's important for us to prioritize screening and early diagnosis so that we can, ensure early initiation to treatment and prevent those unkind health outcomes that we are really committed to avoiding. Before we begin, I'd like to remind you all to please make use of the Q&A function on Zoom to submit your questions and comments. We'll read them in the course of the program. To kick us off, I am honored to introduce our speaker, Bill Wang, who is a CKD patient advocate from Hong Kong. Bill brings with him a wealth of insight and experience on patient-centered care approaches, and I'm very excited to have him guide us through our conversation today. He was diagnosed with polycystic kidney and liver disease over 2 decades ago and underwent a combined kidney and liver transplant in 2018. And since then, he's really been a strong advocate for the patient community, serving on the governance bodies of Hong Kong Kidney Foundation and the International Society of Nephrology, to name but a few. Through his advocacy, Bill is, committed to helping bridge the gap between patients and healthcare providers to improve kidney care worldwide. One example of his contribution to CKD advocacy is a paper he wrote to emphasize the importance of treating patients as whole individuals rather than focusing solely on their illnesses. In the paper, he addresses common misconceptions about person-centered care and advocates for collaborative approaches to enhance patient-provider relationships and improve health outcomes. Well, a warm welcome to you. I'll give you an opportunity now to step on the virtual platform and tell us more about your paper.
Thank you very much, Luanda. Good morning, good afternoon, good evening, whichever place you're from. My name is Bill Wang from Hong Kong. Now, first of all, I'd like to thank GLOPAC for inviting me to talk about a topic that is truly close to my heart and crucial for the future of the healthcare, and that's called person-centered care, PCC. Now, in the era of increasing complexity and fragmentation within the healthcare system, PCC has emerged as a transformative approach to delivering high quality and patient-focused services. We patients certainly applaud PCC's emphasis on treating us as whole persons rather than just our illness or conditions. However, there are myths and misconceptions about PCC that we need to address to ensure it becomes a reality and not just a buzzword. One prevailing myth is that PCC is all about pleasing the patients. Now, whilst our quote-unquote customer experience is important, PCC should encompass so much more, truly understanding our individual needs, preferences, and goals, and tailoring the care deliveries accordingly. Another common myth is about PCC. PCC places an undue burdens on healthcare professionals, adding to their already overwhelming workload. Now, I would respectfully argue that when implemented correctly, PCC can actually help mitigate provider burnout by fostering improved communications, stronger partnerships, and a more coherent, sustainable working environment. Now, at its core, PCC recognizes that each patient is unique with our own lived experience, social determinants, and personal experience. By focusing on the whole person rather than just our specific medical condition, PCC enables a more comprehensive and tailored approach to care. Now, as a lawyer myself who has experienced the rigor of both legal education and healthcare system as a patient, I find an intriguing parallel between these two domains. Both demand not only the transition of knowledge, but also a cultivation of skills, the presence of trust, respect, and well-reasoned disagreement, and a shared commitment to the improvement and well-being of the less experienced party, namely either the law student or the patients. Now, taking my own patient experience as an example, I remember opting for catheter access in my hemodialysis over that through fistula, as being able to continue my routine legal practice using my totally free hands during the in-center sessions was my preferred way of dealing with my renal failure. It was about my values and preference and was a shared decision with my provider. Discussing my combined liver and kidney transplant was another remarkable experience. The provider communication, trust, and partnership was crucial in navigating that journey. Now, the implementation of PCC can be a powerful lever for improving the safety, quality, and sustainability of healthcare delivery, ultimately leading to better outcomes for both patients and the healthcare system as a whole. When providers truly listen to patients, clarify our concerns, involve us in decision-making, it helps identify safety risks. This can lead to improved drug literacy, for example, better adherence, fewer adverse events, and more ultimate therapeutic outcomes. PCC also has a profound impact on the overall quality of healthcare delivery. When patients feel heard, respected, and actively involved in the care, we would be more actively involved and had our voice heard. Excuse me. Now, the benefits of PCC to patients are apparent, and I would also argue that this approach can also have a positive impact on providers and overall healthcare system. When providers are able to engage in a meaningful person-centered interactions, they shift away from a transactional, disease-focused model towards a more holistic, relationship-based approach. This aims to alleviate administrative burdens that contribute to provider burnout, allowing clinicians to focus more on what drew them to healthcare profession in the first place. That is, building relationships and improving the life of their patients. However, journey towards the true embracing PCC is fraught with a multitude of barriers. On the patient side, the disparities in healthcare, health literacy, culture and language barriers, and lack of confidence or empowerment can all contribute to the difficulty in achieving true PCC. Healthcare providers often grapple with heavy workload and time constraints, leaving little room for the kind of in-depth, person-centered communication that is essential to PCC. Rigid hierarchies that prioritize efficiency over patient experience can also pose significant obstacles. At a broader system level, certain models of fee reimbursement, for example, budget allocation, and performance assessment may result in or even incentivize volume over value. Regulatory or policy restraints may hinder the implementations of innovative person-centered approach, while the inadequate support for social determinants of health can undermine the holistic, personalized care that PCC aspire to provide. Now, addressing this multi-phased barriers will require concerted multi-pronged efforts. Fostering a culture of empathy, respect, shared decision-making is crucial, so as investing in providers' communication and patient engagement trainings, and patient medical and literacy improvement. And we patients should and can be empowered and equipped with the tools and resources to improve our health and medical literacy and advocacy skills to actively participating in our own care by being our own advocates. Providers need to have comprehensive development in necessary skills and mindset to embrace in PCC. Healthcare institutions must be willing to restructure their systems, align incentives, and invest in patient engagement incentives. Medical schools have critical roles to in embedding the PCC concept and practice in their academic, clinical, and ethical curriculums for future generations of practitioners. At the systemic level, policymakers and regulatory bodies must facilitate the necessary changes to enable a more person-centered care and value-based healthcare ecosystem. The emergence of artificial intelligence tools have created a dynamic in healthcare delivery. Empowered patients would be more effective users of these tools and contribute valuable data to sharpen these tools further. Now, let me close by saying, under the PCC model of both holistic approach and individualized approach, we patients expect our providers to be our effective polypill. A good multidisciplinary kidney care team should be the renal version of the competent primary care professionals, understanding us as persons who happen to have kidney conditions and address not only our renal treatment, but also our overall well-being. PCC is never a one-way street. No providers or healthcare system can afford to underestimate the resourcefulness of patients under the PCC model. Now, we patients can be effective eyes and ears, sensing clinical signals for our providers. Our lived experience are valuable contextual factors of care plans. Our active participation in studies can inform data points relevant to providers' clinical and research efforts. Our trust and empathy towards our providers can create a powerful advocacy alliance for necessary systemic reform and better resource allocation for all. Now, PCC is not just a lofty ideal or tagline. It is a pragmatic approach that can improve patients' outcomes, increasing provider professional satisfaction, and ultimately create a more sustainable, equitable, responsive, compassionate healthcare landscape for all. Now, with that note, thank you very much for listening.
Thank you, Bill. You've done a fantastic job sort of uploading into this ether here information that I believe will be incredibly valuable. I just wanted to, ask you to please elaborate on how, the lack of patient-centered approaches to CKD screening compromises health outcomes. The way that you described the importance of, person-centered approaches is that if you don't invest in them, you can create this fissure, this alienation of patient from provider, which is not productive for either entities, right? So can you please tell us what we stand to gain by adopting this approach? You talked also about, PCC as an idea that is not a lofty, intangible idea, but it's a very practical set of ideas that help us to really reform health systems to benefit both patients and providers. So I'd love for you to elaborate on that, if you will.
Sure. First of all, let me say I personally very much for CKD screening. And the organization I work for, I volunteer for example, Hong Kong Kidney Foundation, the International Society of Nephrology, all for kidney disease early detection and early intervention and early treatment. I think from a PCC perspective, the screening represents the effort to empower patients in the way that when patient is well informed of their conditions, they have solid base to make further decisions whether they want to go ahead with a particular treatment, or they want a particular intervention, or they want to do something about it. I mean, all these modern medical technologies and all the resources available is all based on the knowledge that people is aware whether they have this kidney conditions. And the tricky part of the kidney conditions, it's a silent disease at the early stages, and then from stage 1 to stage 4, maybe from stage 1 to stage 3 or even 4, you do not really physically feel too many symptoms that you can quickly link to a kidney conditions, right? Mm-hmm. So only if we have a system and we have a competent healthcare providers who are sensitive enough or who are sensible enough to detect the early risk profile of their patients and suggest a sensible screening. And that's not that complicated. Urine test, blood test, and then you can pretty much know your profile, the kidney profile, right? So on the patient side, it really empowered them to make a good decision. Now, on the whole person theory, now kidney disease and heart disease and metabolic disorders are interconnected, right? People have, hypertension, people have diabetes, and a high risk population for kidney disorder. And so these are really related. So, I would say if you go to a family doctor's for a hypertension issue, alert should be really raised in the minds of that practitioners and say, I need to check the kidney function for this patient, right? Just because it's a high risk, it's a risk factor for kidney disease. And so when we treat a patient as a whole person, we just not do not just look at just one disorder. We look at a patient at all, and that includes that for high risk population and kidney screening, kidney function screening.
Mhm. That's really, really insightful. So I was thinking a lot about this session when, I was preparing. I live in South Africa, and I was wondering whether you had any thoughts on whether you believe that, PCC can be universally applied to different countries, regardless of its resource, um, I guess, archetype. So can low resource countries adopt the same, yeah, the approach as well as in a manner that's as efficient as, better resource countries, or do we need to adjust the way that we describe the pathways or apply the pathways to make it effective and sort of beneficial to people living with CKD? Yeah, that's just occurred to me when you discussed some of the solutions you shared in your presentation.
Yeah, thank you. Well, that's a very good question. I think um, as a concept, I think universally apply, right? Now, how do you implement that? I mean, it may be jurisdiction specific, and resources it could be an issue. But having said that, resource-rich countries do not necessarily excel in person-centered care implementation, right? It really depending on uh, the healthcare system create that ecosystem, and how it's a mindset thing, it's a cultural thing, right? So if your providers have that mindset of patient-centered, even though the resources could be limited, he or she would do his or her best
Hmm.
to be uh, empathetic, to be thorough with, say, patients' medical history and even family situation, and just came up with the best possible solution that's suitable to this patient under that, financial conditions or
Hmm.
otherwise, right?
Hmm.
And also, if resources is an issue, here the patients and the providers can form a very strong alliance
Hmm.
to advocate for a better resource allocations.
Hmm.
And politicians may or may not hear, but you know, I think 1 plus 1 uh, certainly more than two. I mean, if we
Hmm.
can form a effective alliance, providers side and patient side, things can be changed. And there are empirical data showing that how when patient voice is heard by the regulators, they are willing to change their mind, even though the same message had been presented by providers previously.
Hmm. Hmm. I totally agree. And I think, the comment you made about the benefit to the system in adopting PCC, one of the things you said was that it also helps to alleviate pressure from resources. And I think, politicians always want to know, is it going to cost me more or can I save some money? So it sounds like as we think about strategies to continue advocating for access to early interventions for CKD, that we can certainly look to PCC as another way to frame the need for policymakers prioritizing early interventions. I want to come back to the comments you made about the culture of the healthcare system. As I was struck by your recommendation that we need to rethink this culture of efficiency. As advocates, we use words like urgent, urgency when we talk about the need to act on issues like CKD. Can you please tell us more about how we can frame that notion so that we're not doing away with the idea that health systems should be efficient, but then also thinking about how healthcare providers can create a beautiful balance between efficiency and really centering the experience, the personal experience of the patients that they support. It seemed to me a comment that struck me quite a bit.
Yeah, thank you. Well,
Yeah.
first of all, I don't think efficiency is a bad thing per se, right? But efficiency at expense of um, rushing through your sessions and misdiagnose people and having all sorts of bad sort of consequences. Those efficiency is not true efficiency, right? It's not maybe efficient but not effective, and you're not helping your patients, right? So really, you strike a balance. I mean, you know, uh, resource allocation is both science and art, and also a result of advocacy efforts as well, right? So, when you have limited resources and politicians and trying to prioritize certain things, patient voice is very important. And
Mhm.
patients are usually the weaker parties and vulnerable parties of all the discussions, right? You have a strong lobbyist from industry and strong lobbyist from professionals and patient voices. It's probably among the weakest, if you will. So if you can have patient voice heard, um, you know, they, they, the equation may change, and the definition of efficiency, you know, uh, need to be rethought through, um, you know, the balance between long term and short term, and efficiency in a short term way, but you
Mhm.
create a long term disaster for patient outcomes, and
Yeah.
that would not save you money. That's not efficient. I mean, so the definition of efficiency is really need to factor in a lot more, just the cost and time at the present time.
Mhm. Thank you. Thank you so much, Bill. That was amazing. I wanted to actually give a moment to our guests to share some of the questions that they may have. We so far have one question, and it really speaks to the opportunity that you described that patients have to advocate policymakers. There's an acknowledgement that patient voices are indeed important and evidence to support that fact. But it's also important, to have patients know exactly what to say. They're a fantastic messenger, but we need to figure out exactly what to say to convince policymakers to adopt PCC. In your talk, you also outlined the fact that, policies must be designed to align with some of the approaches that you described. And so, what are the two or three strategies patient advocacy groups can adopt to engage policymakers effectively?
Sure. My approach would be, make as many friends as you can, make as many alliances as you can. Patient groups make alliances with professional bodies, and your doctors, your nurses, and they can be your strong allies on a lot of things. And they have so much pressures, so many pressures, and have to balance the budget and resources, and they would like to see. Most of them like to see, almost all of them would like to see their patients' welfare to be well taken care of. So that's the alliances, right? Sometimes the policymakers should be your alliances as well. You say, oh wow, they're usually at the opposite side. You need to understand your opposite side. What's their concerns, where they come from, what's on their plate that they are balancing against, and why my how can I make my case to 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 shift the balance, right?
Mhm.
And so, and among the patient groups, there's a way of making alliances, and single patient group may not be that powerful. But if you make alliances of all patient groups, and the voice is formidable. So,
Mhm.
so simply put, make friends, make alliances.
Yeah. Thank you so much. We have another question from someone who wants to know how we can empower those at risk for CKD, so people living with hypertension, diabetes, or obesity, to proactively engage healthcare providers about kidney health and CKD prevention. You, at some level, talked about, well, define what it means when we talk about treating people as whole individuals. And you explained that people generally present with various comorbidities, and so this question, I think, is a way for us to expand on that point. I hope you got the question. If you want me to read again, I'm happy to.
Yes, I sort of get it, but I don't mind if you repeat that question itself.
Okay, so the question is, how do we empower those at risk for CKD, so people living with hypertension, diabetes, or obesity, to proactively engage healthcare providers about kidney health and CKD prevention?
Right. Well, first of all, the patients are the owner of their own health, right? So they need to know themselves. Or we need to know ourselves, right? We need to know ourselves in order for us to make a very good, informed decision to making any action plans. So if I'm coming from a family who has kidney disease, you other generations or my cousins or my sisters or my brothers have kidney disease, you're already in that category of high risk of kidney disease. And let your healthcare provider know about that fact. That single fact will remind them to just to do a very basic CKD screening, right? So I think if our health literacy is good enough to flag the red flags to our providers, and our providers, any responsible providers will do a right thing for us, and the same message to the patients will go to the providers as well. And that's what Kidney Day was about, right? Or the
Mhm.
whole world, the patient groups and the patients and the doctors and the nurses and the professionals and all realize that we need to raise the health literacy of patients, and we need to read early signs of kidney disorder risks. And so just speak up to your family doctors, even if you see a different doctor for a different specialty, and you say, okay, I have diabetes, I have this condition, so I have urine in my blood, do something. I think doctors should be trained as treating a whole person, not just their particular specialty. And
Mhm.
kidney is a very, very common uh, kidney function is a very common sort of biomarker to
Mhm.
test in the
Yeah.
medical settings, but it up to our patients to voice out our
Yeah.
concerns.
Yeah, thank you for that. It sounds like it's important for patients to seek information, not just from a website or a brochure at the clinic, but from their families to find out if there's a history of some of these comorbidities and then to also share that information. But I love that you emphasize the fact that we need to find ways to empower people living with these conditions to be able to use that use their voice to share that information with their providers, and likewise have providers get trained on how to treat individuals like whole persons living with a range of health conditions that they can respond appropriately. So, have a bunch of takeaways from this conversation, which you can see on the slide here. But I think what really strikes me, Bill, is the fact that for us to really achieve health systems that put people at the center of their response, is that we need to reflect on what we what we use as a culture in healthcare, right? We need to really think about having a value-based approach to working with people, not treat them as illnesses or conditions, in in that sort of clinical sense, but really spend the time, invest in the time required to really understand what their needs are as people, because it's not just something that is lofty and that just pleases the patient, but actually results in outcomes that are beneficial for the system, like saving money and also preventing provider burnout. So this is super helpful. So I wanted to thank everyone for joining us on today's webinar, and thank you, Bill, so much for sharing your time so generously with us. Your expertise and knowledge is highly valued. I just wanted to remind everyone that you can access the paper that Bill wrote using the QR code on the screen. So if you take your cell phone, you scan the QR code, you'll be able to access the paper. I highly recommend that you read it and share it with your network. And for those who missed it, GLOPAC hosted a webinar last October to launch the policy paper Screening for Chronic Kidney Disease. You can also access that paper using the QR code below the image for the policy paper. It's really a great resource because it helps us to really unpack how we can advance kidney health how we can advance kidney health globally, excuse me, through strategic screening and ensure that people receive optimal medical treatment and better quality of life, just as Bill has described. The paper is also available in Spanish, French, Telugu, Hindi, Portuguese, and Mandarin on GLOPAC's website. You'll also be able to watch the webinar on YouTube. So we encourage you to please share it widely with your network. You should also get a link to the recording for the webinar so that you can also disseminate via email. Please stay tuned. Please watch your emails very closely. We plan on having a few more webinars of this nature in the Make the Change for Kidney Health webinar series throughout the course of the year, and we look forward to connecting with you then. For now, it's goodbye from me and goodbye from Bill, and we'll connect with you again soon. Thank you. Bye-bye.
Thank you, Lorinda. Bye bye, everyone.